Hi, everybody. I'm your host, Deborah Foreman, and I am the Educational Programs Coordinator for MS Focus. Before we start the webinar today, I'd really like to introduce this year's National MS Education and Awareness Month theme. The theme for 2025 is the whole picture, leading a better life with MS, using a holistic approach to your MS care with a focus on whole body health, collaborating with your healthcare team, and providing support within your MS community. Each year, MS Focus creates a toolkit centered around our yearly theme, and that we send that out to thousands and thousands of individuals on our mailing list. If you're currently subscribed to our MS Focus magazine, then please be on the lookout to receive your 2025 toolkit in the next couple of weeks. If not, please respond to your registration email when you get it from this webinar, and we can just add you to our mailing list so you can get that. To make this year's toolkit and today's webinar possible, I would like to thank our wonderful sponsors, Sanofi, Genentech, Novartis, and EMD Serono. Thank you, everyone, for joining us today, and I hope you enjoy the webinar. Now, I'm thrilled to introduce our speaker. Dr. Ben Thrower is the Medical Director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta, Georgia, and he's also the Senior Medical Advisor for the Multiple Sclerosis Foundation. Dr. Thrower, we're so pleased to have you join us again today to share information regarding what's in the pipeline and finding the right MS medication. I'm going to turn this over to you right now.
Wonderful. Thank you, Deb, and thank you to everyone
Welcome.
behind the scenes at MS Focus. And I hope everyone is having a wonderful March MS Awareness Month. And I am going to see if I can make my technology work and share my screen. All right. Is that coming up on
Perfect.
your end, Deb?
Perfect.
Wonderful. So thank you everyone for joining us. And as Deb said, thank you to our sponsors for allowing this to happen. So what we're going to talk about today is how we navigate through the many different MS therapies that are out there, and then take a look at some of the things that are on the horizon. So when we think about how one goes about choosing an MS therapy, I think one of the important messages that I would love for everyone to keep in mind is there may not be one best therapy. You know, what's right for you may be different from what's right for someone else. And you know, we love our online communities and in-person support groups and the exchange of information that occurs in those venues. But do be aware, you know, it worries me when I see online, someone will say, well, what therapy are you on and what's your experience? You know, that person's experience may be very different from yours. And so just realize we're all individuals, and you know, how we respond to things do vary from person to person. When you're meeting with your MS healthcare team, make sure they understand what your priorities are. We all have, you know, different things that we might consider convenient or inconvenient. We have different risk tolerances. You may have been exposed to other medications in the past, so make sure that your team is aware, and that factors into this concept of shared medical decision making. I look at MS healthcare providers really as kind of guidance counselors. You know, we want you to know everything we know. We want you to have all the information laid out in front of you so that you can make an informed decision that's right for you. So when we think about the goal of any MS disease modifying therapy, it really comes down to this concept of NEDA, N-E-D-A, no evidence of disease activity. And what NEDA means is that we would ideally like you to have no relapse, no progression of disability, and no new MRI lesions. That would be an A+ on your MS exam. What MS disease modifying therapies are not designed to do is get rid of your current symptoms. And again, I don't think we can emphasize that point enough, because you know, the MS therapies are really a different class and type of medication, in that they really don't make something better. With some of the more effective therapies, do sometimes people feel a little bit better at? They do, but that's not really the goal of these medications. We would love it if you felt better on one of these medications, but really the goal is sort of like an insurance policy for the future. If you went on an MS therapy today and we saw you 5 years from now and you look just like you do today, maybe 5 years older, that's a success with these medications. So there are some other things that we would like to see, and there's some newer sort of tests and technologies out there that we're using to help monitor how someone with MS is doing. One of these is the concept of quantitative MRI metrics. We've done this in MS research for a while now, but you're seeing it more in the real world as well. So this would be the idea that rather than us just looking at your MRI and saying, okay, I don't see any new spots. This year's MRI looks like last year's MRI. We take it a kind of a notch further, and we use some the computer software that's out there, some of the artificial intelligence programs to really objectively measure these things. And there are a lot of different things that can be measured. The how big your brain is, the brain volume, the volume of your white matter lesions, something called cortical gray matter volume, a deep part of the brain called the thalamus. And we can actually look for the number of enlarging T2 lesions. This computer technology, including artificial intelligence, really makes these things possible and does it in a way that just the naked human eye cannot do that. So this is an example of one of those types of programs and what it might look like. There are numerous programs out there. We use one at our center called IQMS. This is out of a group from Sydney, Australia. And what you see here is so we've got last year's MRI and the updated MRI, and you can see all of the white spots with the MS lesions. If you really went in and sort of looked, you would see that there is a difference there. The updated MRI does have some new stuff going on, but it really takes looking at it, in a very detailed way. What these computer programs do is they make it a lot easier for us to see. So what these color codes are, so the red areas are old MS lesions. The blue area is a new lesion, and the green area is an enlarging lesion. So it really makes it just pop out at us in a much more obvious way. What this shows is this is actually measuring the thalamus. The thalamus is a deep gray structure in the brain. When I show someone their MRI, I can point to their thalamus. It's very difficult for me to look at this year's MRI versus last year's MRI and tell you whether your thalamus has changed in size. These computer programs can do that. And we're learning that some of these things like thalamic volume are really are correlated with how a person with MS is doing. So that sort of stuff would be up here at the top of the MRI report. And then we get some other cool things down here in the bottom. These are sort of measures of whole brain volume. This is the thalamic volume. This is the cortical gray. So the cortical gray is the outside squiggly part of our brain. Even though we call it gray matter, there is myelin in that gray matter, and that myelin is probably very important. So these are actually graphic sort of measurements of that. And what you would see with the next MRI is that they would plot that next time point out so that over time, we're going to be able to really objectively measure these things and show whether there is a change over time. There are some other blood tests that we might use as measures of how effective your MS therapy is. Neurofilament light chain is one of those blood tests. Neurofilament light chain, if you will, is the protein that makes up sort of the framework of neurons and axons in the brain and spinal cord. If something is damaging that neuron or axon, that neurofilament light chain protein is released into the spinal fluid and ultimately into your bloodstream where we can measure it. And so it's a marker for neuronal degeneration. It's not specific to MS. I mean, we obviously use it in our MS world, but it could also be elevated in someone with a stroke or brain tumor, traumatic brain injury. But it is something we could follow. Probably the most sensitive use of that would be in someone who's newly diagnosed, maybe a lot of active inflammation. You would expect their neurofilament light chain to be high because those cells are being damaged. We put them on a therapy, maybe we repeat the neurofilament light chain, and we would expect it to go down as a marker that we're actually putting that inflammation out and stopping that cell damage. Another blood marker that we use is called GFAP, or glial fibrillary acidic protein, also a marker for inflammation and cell damage. So when you put all of this together, when you think about choosing your therapy, some things to think about, they're going to help guide you one direction or the other. We do need to think about what type of MS you have, because some therapies are approved for one form of MS, but maybe not another. We think about the convenience of the medication. Do you find an oral medicine more convenient than an IV versus an injectable medication? The safety, the effectiveness. And then the last bullet that we would like to not have to consider, but unfortunately in the real world we do, is what's my insurance going to cover? One of the things that we sometimes deal with insurance companies are called step edits. A step edit is your health insurance carrier saying, I know the doctor wants to use drug C, but you have to try drug A and B before you get to C. And it's frustrating. Sometimes there's not a lot of medical rationale as to why your insurance company is going to make you jump through those hoops. There's a lot of movement in the MS world towards going to highly effective therapies as our first line treatment. And sometimes we have to butt heads with the insurance carrier because they want to try something else before they let a person try that more highly effective treatment. So when we think about the types of MS, just a little kind of reminder for all of us, uh, we have clinically isolated syndromes. These are individuals who've only had one clinical attack. We have relapsing remitting MS, secondary progressive, primary progressive MS. In recent years, we've started dividing secondary progressive into with activity and without activity. With activity would mean that you're either having ongoing relapses and or new lesions on MRI. When you take clinically isolated syndromes, relapsing remitting MS, and secondary progressive with MS with activity, we lump those together into what we call relapsing forms of MS. Most of our FDA approved treatments are approved for relapsing forms of MS, clinically isolated syndromes, relapsing remitting, and secondary progressive with activity. When we think about primary progressive MS, as we are here today, only Ocrevus or ocrelizumab is approved for primary progressive MS. And we're going to come back to this thought in a little bit when we look at the horizon of the pipeline. Currently, there is no FDA approved treatment or therapy for secondary progressive MS without activity. Hopefully, by the end of this year, that will have changed, and we'll circle back to that in a moment. So I'm just going to go quickly through the different classes of drugs in the most kind of basic way, just to kind of remind ourselves what are the different options that we have available. We could spend quite a bit of time on any one of these classes, but when we think about our older, or what we call platform therapies, these are your beta interferons or glutamer acetate. When we think about the pros and cons of these medications, they have a wonderful safety profile. These medicines have been around forever. There are really no surprises, but they're not as effective as some of our newer therapies. One of the important things to take home from today is that if you are on one of these older therapies, and we certainly have lots of people who are still on these older therapies, if you are stable, or in other words, if you have achieved NEDA, no evidence of disease activity, and you're happy with that medicine, there's nothing to say that you have to switch. So even though in theory we have more effective drugs, if for you as an individual this medication is achieving stability, then it's okay to stay with that. So one of the other classes of drugs that we have would be the oral fumarates. So the original one of these would have been Tecfidera. We now have the generic version of that, or dimethyl fumarate. There is Vumerity or diroximel fumarate, Bifiratam monomethyl fumarate. I would say that these drugs are in the modest, some might argue modest to high efficacy range. In terms of side effects, when people first start these, sometimes there can be some GI side effects, and we do need to monitor blood over time. There can be issues with low lymphocytes, which, if you let that go to extremes, could lead to an increase in infections. We have the oral S1P receptor modulators. So our very first oral MS disease modifying therapy was Gilenya. There's now generic fingolimod. I've got a typo there, got to add a G. Zeposia, Mayzent, and Ponvory are the other options within this class. I would say that these are in the modest to high efficacy range. They have a unique mechanism of action. They don't kill any cells in your immune system, but they do lock up the lymphocytes in the lymph nodes and prevent them from getting out and causing inflammation. Depending upon which one of these you're looking at, there can be cardiac side effects. With Gilenya or fingolimod, we have to do first dose observation or have to keep a watch on your EKG, heart rate, and blood pressure for 6 hours after the first dose. There can be macular edema, liver function issues, increased risks of infections, sometimes with these medications. So Mavenclad is another oral medication that we have, or cladribine. It is unique in that we only do really 2 oral courses. So you take a course now, a year later you do another course, and then in theory you're done with that. There's certainly research looking at redosing over time, but there is long-term data showing that this drug seems to have a very long protective effect. It does work by actually knocking down populations of both B and T cells temporarily. And the thought is that when those cells then repopulate, they come back in a less inflammatory state, or maybe your immune system has essentially been reprogrammed. This would be a highly effective therapy. During that time when the white blood cell counts are low, there could be increased risk of infections. We have to monitor liver function studies, and ideally we like to have cancer screening done prior to starting this medication. Tysabri or natalizumab, once a month IV infusion. There is certainly research looking at doing what we call extended interval dosing, or going to 6-week dosing with this medication. A highly effective drug. The big side effect we think about when choosing this medication and then monitoring this medication would be PML, or progressive multifocal leukoencephalopathy. We've certainly learned a lot over the years about how to select appropriate individuals for this medicine and then how to safely monitor them over time. Some individuals on this medicine do have a wearing off effect, so they get their dose and maybe 3 weeks later they start feeling like their energy levels are dropping off a little bit. So that wearing off effect is sometimes lovingly referred to as the crap gap. Doesn't occur in everyone, but it can be an issue for some people with this medicine. The patent on Tysabri expired a couple of years ago, and so now there is a potential competitor, or what we call biosimilar version of Tysabri, called Tyruko. This drug is FDA approved, but is not currently being marketed. One of the challenges with this biosimilar version is that due to some patents and whatnot on the JC virus antibody testing, the JC virus antibody test that we do right now belongs to Biogen, the manufacturer of Tysabri. So the manufacturers of Tyruko are going to have to do their own JC virus antibody test, and that's what we're waiting for, is to get verification that test is going to be valid and let us safely use this biosimilar version of the drug. B cell therapies are certainly one of our important classes of medicines, disease modifying therapies for MS. This would include Ocrevus or ocrelizumab, Briumvi, ublituximab, Rituxan, and the biosimilar versions of Rituxan, which are Ruxience and Truxima. And then Kesimpta. All of those in the first bullet are every 6-month IV therapies. Kesimpta is a once monthly subcutaneous injection. These are highly effective medicines. With the IV versions, we do have to monitor for infusion reactions. We do lab monitoring to make sure that we're not pushing too hard with these medicines in a way that would put you at risk for infections. And there have been some cases of an inflammatory bowel reaction or inflammation in some people on these medications. And then kind of wrapping up just classes. So one that's in a class of its own would be Lemtrada or alemtuzumab. This is an IV therapy given in two courses a year apart, highly effective drug. It's had some safety challenges, I would argue. So there are thyroid issues. There have been some secondary autoimmune conditions. We do have to watch for infections and then some issues with liver damage. And it certainly would be a highly effective therapy. So, you know, when we think about, choosing, what therapy to be on, I think the other thing that we should talk about is there a point when you can choose to not be on a therapy? And so this is an area of quite a bit of research and maybe even some controversy and arguments at some of our MS meetings. So why is it that we might be able to stop an MS therapy? As we age, our immune system does sort of, if you will, calm down in a process called immune senescence. MS is driven by a dysregulated, relatively overactive immune system. So if with normal human aging, there is a calming of the immune system, maybe we reach a point where we don't have to be on an MS therapy. Some studies have suggested that individuals who've been stable for years might be able to stop their therapies. I would say the strongest research for this has been with the older platform therapies, your interferons and glutamers. And some of these studies have gone as young as 55. As I said, this is not a completely settled science. There are people who argue that there may be progression of disease that we see that is subtle in older individuals when we stop these therapies. Other people would argue that you can safely stop these therapies. Um, Personally, I would say we I am a believer in the therapeutic benefit of vitamin D replacement in MS. Some studies have argued that vitamin D does have an immunomodulatory effect. Other studies have not shown it. So when we do elect via shared medical decision making to stop treatment in an older individual with MS, we certainly continue vitamin D replacement if it's appropriate for that person. So some of those people you could argue are still on a disease modifying therapy, albeit not a hugely or highly effective one, but it is still, it does offer protection. So we do continue these individuals on vitamin D replacement after stopping their disease modifying therapy. So what are some of the things that are on the horizon? We mentioned that there is currently no FDA-approved therapy for secondary progressive MS without activity. Hopefully that's going to change around September of this year. So tolobrutinib is in a class of drugs called BTK inhibitors. These are Bruton tyrosine kinase inhibitors. They work on B cells, but in a very different way than from our current B cell therapies. One of the things that we think drives this kind of slow progression without a lot of relapses is the concept of smoldering inflammation or very low level inflammation, perhaps driven by a cell in the central nervous system called microglial cells. We don't think any of our existing MS therapies address that very, very low level inflammation, but the hope is that this tolobrutinib does. In studies, it was shown to slow progression in this form of MS. We're going to have to see kind of what the safety data looks like. What is the lab monitoring going to look like? But it will certainly be a welcome addition to our MS therapy kind of regimen. Some other things that are out there on the horizon, there is a drug in testing, interestingly given as an intranasal drug called foralumab. It is an anti-CD3 monoclonal antibody. It's being also looked at in secondary progressive MS without activity. It's early, so phase 1 studies are complete and it is in phase 2 testing. just for frame of reference, when we think about the phases of research, what is it, what sort of time frame are we talking about from concept to completed phase 3 studies and FDA approval? On average, we're looking at about 12 years, in that time frame. There's an interesting phase 2 study that is starting up here quickly, looking at an anti-Epstein-Barr virus messenger RNA vaccine. We know the Epstein-Barr virus is a very important environmental sort of component for people developing MS. MS does result from this kind of complex interplay between genetic factors and environmental factors. And we think Epstein-Barr virus is one of the more important environmental factors. So the idea with this study is that you would offer this vaccine as a treatment very early in MS, maybe clinically isolated syndrome, early relapsing remitting MS. If it works there, I think the natural evolution of that thought is, do we vaccinate the general public? Do you offer that Epstein-Barr virus vaccines to the general public? Some researchers have theorized that you might reduce the risk of multiple sclerosis by 40 to 50% or more just by preventing Epstein-Barr virus infections in the general public. There is ongoing research with autologous hematopoietic stem cell transplantation. This trial is called the BEAT MS trial. Just as a reminder, so with HSCT, we are taking immature immune stem cells from your blood, saving those, freezing them, and then using some sort of chemotherapeutic regimen to sort of wipe out your existing immune system, give you your own immature immune cells back, and let you reboot a fresh immune system that hopefully doesn't have the memory to attack myelin. HSCT in some studies has been shown to be incredibly effective in the right patients. The right patients probably being people with highly inflammatory forms of MS. Lots of research on mesenchymal stem cells for reversing disability. We have a program that we did a couple of months ago on repair strategies for MS, and I would refer you back to that where we go into this topic of repair quite a bit more. Frexalimab is another monoclonal antibody that's in testing right now. Again, looking at secondary progressive MS without activity, IV infusion given every 4 weeks, and it's a little further along in testing. It's their phase 3 testing phase. I think one of the things that gives me great hope is that we're seeing so much research focus on secondary progressive MS without activity. We're also seeing new trials in primary progressive MS. I think for many people in the MS community living with progressive forms of MS, there has been this sense of, what about me? You go to meetings or seminars, and you hear so much about relapsing MS, and we have great therapy options for relapsing forms of MS. We just have not had as great options for progressive forms, and hopefully we're seeing light at the end of the tunnel in addressing that. Just an update on clemastine or clemastine. There's a lot of interest in looking at repurposing known FDA-approved molecules. So taking something that's already out there, it's FDA-approved for one health condition, and seeing if just by luck, does that medication perhaps do something else, like repairing myelin in the central nervous system. A lot of this research is coming out of University of California, San Francisco. They have a great test tube model that lets us screen molecules very quickly to see if they might work in that test tube. And then that allows us to very quickly move into human testing. You don't have to do human safety testing because this medicine's already FDA approved. You don't have to do any animal testing. So it moves things along very quickly. Clemastine is an antihistamine. It's the active ingredient Tavist. So what do we know about this so far in terms of maybe repairing damage? slightly mixed results. So we have early trials that looked at individuals with MS who had optic neuritis with permanent visual loss. And the studies looked at 50 individuals, all treated with clemistine. All 50 had some degree of visual recovery. And more sensitive MRI studies that look for evidence of myelin repair showed that all of these individuals had some degree of myelin repair. It's very exciting, very, very hopeful. A little bit of negative news in a follow-up study or later study that looked at walking in individuals with more progressive forms of MS. That arm, the clemistine arm in that study, was actually stopped prematurely because 3 individuals in the clemistine arm actually looked like they got significantly worse. We don't know if it was a statistical anomaly. Maybe it had nothing to do with the clemistine, but that's where we're at right now with clemistine. I would say, just on a personal note, if you given what we know right now, if I have someone who comes in and says, hey, I'd really like to try this to see if it might improve something. Ideally, you'd have someone with optic neuritis, with visual loss, because that's where the best data was at. Am I willing to have someone try this off label? I am. And again, this goes back to that concept of shared medical decision making. What is your risk tolerance? As long as you go into this, fully informed, and I think people have the right to make a medical decision on their own. Um, this is going to be off label. Probably insurance is not going to pay for the clemistine. It's a pretty decent dose of clemistine. This drug comes in as a 2.68 milligram tablet. You would take 2 of those twice a day for 6 months. It's an antihistamine. It can be pretty sedating. So if someone's going to try this, we have to make them aware that, a lot of people with MS are already dealing with fatigue, and we're adding something that could certainly compound that fatigue. So with that, I am going to stop. I think that's just kind of a broad overview of kind of some of the thoughts that we go into in helping you choose the most effective and appropriate disease modifying therapy for your MS. A little kind of glimpse at some of the exciting things that are on the horizon. And now, Deb, we will throw it open for thoughts or questions.
Awesome. Thank you. Thank you. Okay, so Trisha was the first one to ask a question. She said that she's 56 years old. Her name is Trisha. She was diagnosed with MS in 1991 on the lottery for beta-seron. And in 93, she says base serum. For 31 years, she was on it. Um, Maybe she meant beta-seron and it came out base serum. I didn't know if that was
It
something
was where
different.
they came out with beta furon, or Xtavia was the kind of a generic version of that.
Well, she was on something for 31 years and she stopped it in August of 24 because she felt like it really might not be doing as well as she had experienced prior to that for so long. And she did not develop antibodies to it, so she didn't stop for that reason. But she was thinking it might not be doing so great for her anymore. So her question is, after that long on a medication, what would you say after being on beta-seron for that long? Do you have any suggestions? Is this something else that she should go on? She had no side effects from that, and she felt great all that time.
So she kind of looks like the individuals that were in one of our studies that called the DISCO MS, or discontinuation MS trial. So, people in this trial were typically on interferons like beta-seron or Copaxone or Avonex, had been stable. They were over 55, had been stable for years, no relapse, no new MRI lesions, and these individuals were randomized to either stay on their treatment or go off. In general, the people who went off didn't look a whole lot different than the people who stayed on treatment after 2 years of observation. We've certainly had this discussion with a lot of people, and have had many individuals go off of therapies like beta seron. Um, if by every measure we have, looking at her clinically, looking at her MRIs, do you do some of the biomarkers like neurofilament light chain? If she's stable, maybe she's an individual that doesn't need to go back on anything. one of the areas of a lot of interest is if she did need to go back on something, what do you do? Well, certainly going back to her beta serum would be an option. If she did well with it, she tolerated it. A lot of individuals we see that have been on injectables for a long time, that they kind of get burned out on doing shots, and so they're not so excited about going back on another injectable. So, things that are looked at for those individuals. Maybe we look at a drug like teriflunomide, the generic of Aubagio. It's a modestly effective drug, good safety profile. Maybe that's a nice exit strategy. Maybe you look at something like Mavenclad, where you do the two doses a year apart, and then you're done. So maybe that's the exit strategy to get someone off of a drug like beta seron.
Great. Thank you. Thank you, Trisha. I hope that answered your questions. Karen wants to know, do you have to use contrast for the IQ MRI?
So the IQ MS study, we don't. There is a part in there where they count the number of enhancing lesions. There's a move for people who have been dealing with MS for a while to maybe not do contrast. There are studies that show we see most of what we need to see on an MRI without contrast. There are some studies also suggesting that the MRI gadolinium, the contrast, may be sticking around in the central nervous system longer than we knew that it did. We don't know of any health issues that go along with that, but I would say if we can avoid contrast, in individuals who've been dealing with MS for a while, I would rather not give the contrast. So although there is a section on the IQMS that looks at enhancing lesions with contrast, you don't have to do that. We just kind of skip that part. Newly diagnosed individuals, may still get a couple of MRIs under their belt with contrast just to kind of establish a baseline and look for inflammatory activity.
Thank you. Elizabeth's asking regarding DMTs after age 55. What about the research which shows that menopause can make MS worse and that DMTs should not be stopped?
Yeah, so that's when we talked about some of the controversies and the arguments against stopping it, that would certainly go into the maybe we shouldn't stop. I think that the whole idea of menopause and what it does to MS is particularly challenging because you not only have menopause, but then you just have normal human aging. And so separating those two out is not always an exact science, but that would go and file that one under the side of the argument that where people are arguing not to stop a DMT.
Thank you. And does clemistine help with heat sensitivity?
We would not expect that. So again, where we've got hard data is in the people with visual loss. That it improved their visual acuity, and we would assume it did that by remyelinating. Um, I wouldn't think of it as something that would necessarily help heat sensitivity, although you could argue, well, if it made new myelin, we think heat sensitivity occurs due to nerve fiber fatigue due to demyelinated nerve fibers. So I just don't think I'm quite there yet that I would say I would expect to see that. When we think about helping heat sensitivity, obviously cooling strategies like cooling vests, staying well hydrated. And then even though it's not what the drug is approved for, dalfampridine or 4-aminopyridine, we used to use 4-aminopyridine, which is the compounded version of that molecule. We always thought of that as something that helped with heat sensitivity. Dalfampridine is specifically approved to help walking speed, but as a side note, it does help heat sensitivity in some individuals.
Thank you. This person says that they're 44 years old and oh, yep, 44 years old, was diagnosed with relapse remitting in 2022. I have been on Kesimpta since the beginning and I'm doing well with no new lesions and no new symptoms. Some symptoms seem worse though. Would it make sense for me to switch to Mavenclad? I like that my immune system would not be continually suppressed with Mavenclad versus Kesimpta.
I think that's one of the hardest, questions that people with MS and healthcare providers deal with. So the individual who is on a highly effective therapy like Kesimpta, They're not having relapses. They're not having new lesions in MRI, but maybe just some subtle progression. So the term that we're using to describe that is PIRA, P-I-R-A, progression independent of relapse activity. And to be really honest, I don't think anyone knows what the best thing to do for that is. Is moving to a different highly effective therapy an option? Absolutely. So maybe moving to something like Mavenclad. If Pira, if that situation is driven maybe by this very, very low level inflammation, the smoldering inflammation, we have to be honest and say we don't know if any of our disease modifying therapies currently address that. Would tolobrutinib in the future address that? There's a lot of the problem with tolobrutinib is whereas it works really well for secondary progressive MS without activity, it probably is not as effective as like a Kesimpta or Mavenclad at putting out the big forest fire, the really active inflammation. I think what we're going to see in the future is combination studies, put these things together. If Kesimpta addresses 95% of the problem, what about adding tolobrutinib to hit that last little 5%? It's interesting. It's a theoretical issue right now. I don't think we can do it until we have some data to back that up.
Okay. And how long do you typically leave people on Zeposia? I'm 65 years old and have been taking it for 3 years, following Gilenya for another 2 to 3.
So that situation would be kind of we're in kind of that realm of the controversy. Do a person who's 65 who has been stable, can they safely stop a drug like Zeposia? There was a study that looked at older individuals, going off of more highly effective therapies. They looked at Ocrevus, Gilenya, and Tysabri. The group that actually did the best when they went off treatment was the Ocrevus group, and that may speak to how that drug works and maybe some prolonged immune protection you see with Ocrevus. The problem with our S1P modulators like Zeposia and Gilenya is that there is the potential for rebound. So when you stop those drugs, there is the potential that active inflammation could come back. We see that with Tysabri as well. When people have been off of Tysabri for about 3 months, there is some risk of their MS acting back up. So I think it's a discussion to have with your medical team to talk about the risks and benefits. Do you stop it abruptly? Do you maybe go to every other day dosing for a while and see if you get away with it? I think all these things are open for discussion.
Thanks. Here's another interesting one. Should I be concerned that my MS specialist says I don't need to have any follow-up MRIs as long as I don't have any new symptoms? I was just diagnosed with relapse remitting in 2022, and my last two follow-up brain MRIs, most recently in February, were good with no changes. He said I could wait 2, 3, 4 years even before needing another one.
That's a very much a judgment call. So in big picture, we know that there is people can feel good and not have relapses and still have new lesions on MRI. So that's especially true early on in the course of MS. Old data showed that for every one relapse someone with MS has, there can be 5 to 10 new lesions on MRI that are not giving them any obvious symptoms. So in general, there can be asymptomatic new activity on MRI. Now, if their MRIs have been stable year after year after year, and then maybe they're 60 years old, maybe at some point we can back off a little bit. Again, that goes back to the whole shared medical decision making. I see individuals who've had a stable MRIs for many years and they still like to get their yearly MRI because it makes them sleep better at night. They just like the reassurance that nothing's changed, and I am absolutely okay with that. Um, Other people, they have horrible claustrophobia. Maybe they've got a high copay, on their MRI, and they would rather lose an eye than get in that MRI scanner, even with sedation for the claustrophobia. So again, there are a lot of variables that go into that, but going back to her original question, MRI activity can certainly occur even when people feel okay.
Thank you. Julie's asking, would Copaxone be a potential choice for a 70-year-old person with relapse remitting for active disease when another DMT such as Mavenclad was far too much strong for them?
Yeah.
So this person has multiple autoimmune diseases and high risk for infection.
So I would say Copaxone is certainly an option for that. So I mean, the appeal to Copaxone or glutathione acetate is, I would argue, is probably the safest MS therapy we've ever had and probably ever will have. It's the only MS therapy that we don't have to do any lab monitoring with. It has no potential for compromising or suppressing the immune system. Is it as effective as Mavenclad? No. But for someone in that situation, it may be enough, and certainly it's not going to put the person at risk for infections.
Thank you. Where does CAR-T clinical trials fit into the future of treating MS,
Yeah,
specifically
yeah, I probably
PPMS?
should have put that one up there as well. So CAR T is is not a brand new therapy. It's certainly been used in other health conditions like certain cancers. So it's the idea is you're sort of reprogramming T cells to do something beneficial, whether it's a cancer or an autoimmune disease. There are, multiple research groups interested in that. I think most of the trials are in the early phases. I don't think there's anything at the phase 3 level that I'm aware of. So we still have a little bit of time before we know if that's going to be, a keeper for MS.
Okay. And if you have PIRA, is it necessary to switch DMTs?
We don't know really. So in my mind, PIRA, progression independent of relapse activity, could be driven by two things. One would be the smoldering inflammation that we've talked about. The other thing that probably contributes to this slow progression is loss of neural reserve. So neural reserve is how much can I injure my central nervous system and I get away with it. So maybe I have a lesion on MRI, but it's not causing me symptoms. As we age, we lose neural reserve. That's not an inflammatory thing. That's more of, sort of a normal human aging thing. I don't think we have any current disease modifying therapy that's going to address that part. I think the challenge, in a person who has PIRA is how much is loss of neural reserve, how much is this smoldering inflammation. I think once we have tolebrutinib, that's going to be a discussion to think about. If someone is older and they're having progression in spite of a disease modifying therapy, do we switch them to tolebrutinib that has this very different mechanism of action and has been shown to slow progression in that individual? Yeah, again, we'd love to have data about adding it to rather than switching to, but we're going to have to see what that research looks like.
Thank you. Caroline wants to know with the S1P modulator drugs, what would be an exit strategy and how would you transition to a drug like Ocrevus?
Yeah. So again, one of the challenges with the S1Ps is there is that, slight potential for rebound when we stop them. Going to Ocrevus, so you're going from a drug that locks up white blood cells in the lymph nodes to a drug that actually kills a certain population of B cells. Most of us would like to see your lymphocyte counts on blood work at least getting back into the, if not normal, closer to the normal range. So we're going to stop your S1P modulator, watch those lymphocyte counts closely. I'd like to see them going, up above 500 if they were below that, trending in the right direction. It's not. I wouldn't say it's an exact science because there's this balance between wanting to see your lymphocyte counts recovering, but not wanting to leave you off of treatment so long that you're at risk for relapse. Um, it wouldn't be unusual to see a 2, maybe 3 month gap between stopping the S1P modulator and starting your B cell therapy like the Ocrevus, depending upon how quickly your lymphocytes are recovering.
Thank you. And I may be pronouncing this incorrectly. I'm sorry, but Michael's asking, have you had any patients who have tried exomes? Um,
Exosomes are
exosomes.
kind of another one of those things on the horizon. I have not had anyone. They are certainly being looked at in the MS world. Um, Nothing that is FDA approved. I mean, you would clearly be doing something off label. So I just don't have any experience with any of our patients trying that yet.
Okay. And this is a 51-year-old female recently received a diagnosis and was told that they have a mild case of MS. Vulmerity is what they prescribed to this person. What do you think? Should that person get a second opinion? She said, or he said, that they have lesions and experienced double vision in 2014 and with no recent symptoms after that.
So when we talk about mild MS, I mean, it's a subjective term. How one, MS center defines mild might be different from how someone else defines mild. Clearly, there are individuals who follow a milder course than others. And back in the days before there were any disease-modifying therapies, Mayo Clinic collected a lot of data on individuals with MS, and they felt like about a third of individuals with MS followed this milder course. Maybe this is a person who at age 90 looks back over their MS life and says, it was a nuisance. It was not a disabling condition, but it was a nuisance for me. But again, it's very subjective as how you define that. Vumerity is as one of the fumarates is kind of in that modest to maybe highly effective range. And so I think it's a perfectly reasonable option for someone like this. This sort of gets into what is this individual's priority? Would they prioritize, say, safety over being on a more aggressive drug, or are they someone that really wants to be as aggressive as possible? If they are wanting to be as aggressive as possible, even though this is a milder form, they could certainly look at something like one of the B cell therapies or a Tysabri in that situation. Where people living with MS have their priorities and their biases. They might want, say safety over efficacy or efficacy over safety. Healthcare providers have biases too. I mean, so I would say our bias, and I think a lot of MS centers have this bias, is our kind of default is to go to a more highly effective therapy. So, and I try to put that up front with individuals and say, if I'm picking for myself or I'm picking for my family member, I'm probably going to steer you towards a B cell therapy, a Tysabri, a Mavenclad over these other things. If that doesn't fit with your priorities, obviously you win. You're picking, it's your body, your health, but that's my bias.
Thank you. And I know you discussed Ocrevus a few minutes ago, but is Ocrevus Zunovo the same thing? Because this person's asking about your thoughts on that.
Yeah, so Ocrevus, the Zunovo is the new subcutaneous version. So there's a little interesting kind of battle with the B cell therapies with the IV versions. And it really has to do with the convenience of who can be given more quickly. So Ocrevus, when it originally came out, could be up to a 6-hour infusion. Then there was research looking at the more rapid infusion rate, so we get it down something more like 2.5 hours or so. And then Briumvi comes out. That's a 1 hour infusion. Well, now Ocrevus came out with their subcutaneous version. So this is rather than intravenously, a butterfly needle is going to be put under the skin of the abdomen. 23 milliliters of Ocrevus is going to be given over 10 minutes. So very fast. We don't have any indication that as you look at the different ways we give Ocrevus, this is not an effectiveness thing. They're all equally effective. It really is a convenience thing. So if that's something that's really important to you, you want to get in and out of that infusion chair, you got places to go. It certainly is an option.
Thank you. Vera said that she's 52, JC virus positive, and was diagnosed with relapse remitting in 2018. She's been on dalfampridine and Ocrevus since the beginning, was diagnosed with SPMS in 2021, no new lesions on her MRIs, but she's progressing in 2022. She was told that she's a no option patient. Is there anything else that she can do to protect her from disease progression?
So let's say that if she's still on Ocrevus and that kind of speaks to that PURA, the progression independent of relapse activity. I think one of the biggest challenges we have is, so if someone's on a highly effective therapy and they're still progressing, do they really have secondary progressive MS, or do they have partially treated relapsing remitting MS? And if we took them off their therapy, maybe now we see the active inflammation blossom again. So the only way we would know that is if we took the person off of treatment. I'm very cautious about how we use the label sometimes because when we use the term secondary progressive MS, now if it's with activity, with relapses or lesions on MRI, really all the treatments are still in play. Insurance will cover those. But if it's secondary progressive without activity, as she stated, technically there is no FDA approved treatment for that. And so we may essentially close the door on the patient's treatment options, once we use that label. Once tolobrutinib is, assuming it gets approval later this year, I think that's an option if someone truly has secondary progressive without activity. But if she's still on Ocrevus and she's progressing slightly, I'm very cautious about what label we use in that situation because that is not the natural history of MS. That is a modified version of her MS because she's on treatment.
Hmm. Okay.
Yeah.
Thank you. Can you take Aubagio if you also take Wegovy?
Yes. So there were obviously a lot of people out there are looking at the GLP-1 drugs for weight management and diabetes or both. And so there was a study recently that looked at the safety of those drugs in people with MS, regardless of their therapies, and there really were no contraindications. So yes, you can be on those two together.
Thank you. What are your thoughts on extending Ocrevus infusions to 8 to 9+ months apart?
Yeah, so there was a study that looked at 9 month dosing versus the usual 6 month dosing, and in that study they really did not see a difference in the effectiveness. I think what was interesting that we're seeing too is in that with that 9 month dosing, the B cells are starting to come back, but it looks like they might be coming back in a kind of a reprogrammed, less inflammatory state. So we do have individuals that are doing 9 month dosing. And so far, so good.
Perfect. And I pretty much know what you're going to say on this, but should a patient get a second opinion? What are your thoughts?
It's your body, it's your health. No one's ever been hurt by a second opinion. I would just throw in my 2 cents worth. If your physician is offended by you getting a second opinion, that's probably not a great thing, and there just should be no egos involved in any of this. And so, yeah, I think getting a second opinion should be absolutely fine.
Thank you. Caroline is asking, she said that you mentioned Zeposia being a modest to high efficacy drug. She didn't hear about many people on this medication, and is it still being prescribed?
Yeah, absolutely. I mean, yeah, the oral medications, I would say Zeposia is one of the more commonly used ones. So yeah, um,
Okay. So now I don't see any other questions here. Casey, if it's in another area that I'm not seeing, please let me know because I only have I couldn't see anything for chat. I only see um hopefully nobody's raising their hands. I can't see that. But
Um, there are a few questions in chat. Um,
okay. I'm not able to
I'm
access that for some reason.
okay. I'm not sure why, but I'd be happy to give one or two in the couple of minutes that we have left, if Dr. Thrower is okay with
absolutely,
that.
absolutely.
Okay. Here's one from Keith who says, "What causes the fatigue and general drowsiness in patients with MS? Is it more mitochondria related, difficulty moving muscles, or is it something else?"
The honest answer is we don't know. So lassitude or that kind of non-exertional, non-heat related fatigue is a big issue. It's very common in MS. There have been a lot of theories as to what might be causing that, but we really don't know. Some of the things you mentioned, could it be mitochondrial dysfunction? Could it be just all of the extra effort that some people with MS have to exert to carry out activities of daily living? Does that contribute? Absolutely. But in spite of it being one of the most common things that people with MS deal with is probably one of the more poorly understood symptoms that we see.
Okay. And Keith's second question is, are there any physical modalities or treatments that you've found effective to improve quality of life and maintain movement?
Absolutely. So, I'm a little biased. I work at a rehab hospital, so I'm surrounded by wonderful physical therapists and occupational therapists and speech language pathologists and exercise physiologists. So, we want you to take advantage of those things in whatever way your community offers them. So, if you can access a comprehensive integrated MS therapy, wonderful. If your MS team is sort of in pieces in the community, that's okay too. But I really believe people with MS need to keep moving and keep exercising as much as possible. People with MS put up with a lot. Some of the walking issues that we see with MS are sometimes largely that people are just toughing it out, and you don't have to do that. Uh, you mentioned earlier that the fatigue that we see with just the extra exertion, that's a very real thing. And sometimes something as simple as just addressing foot drop to put someone's walking back into a normal sort of motion will improve energy levels just because you're not fighting, that dragging leg all day long.
Okay.
And one final question. Mike asks, have you heard of only going on Ocrevus for 1 year after being on no DMTs for 15 years? My last MRI had two new lesions. I'm 67.
So there's no time limit on on Ocrevus. There's not any reason that a person would have to stop, after a year. Again, there is this research suggesting that maybe B cell therapies are helping to reset the immune system, and that maybe that effect lasts longer than we knew. So that may be where your healthcare team is coming from, but there's no reason that you would have to do only a year of treatment.
Hmm, okay. Is that it, Casey? Do we have time for
We are at the top of the
at the
half hour,
hour?
yes.
Yep. I will tell everybody, thanks, Casey. Tell everybody that Dr. Thrower does a Q&A hour for us every month, every other month rather. So you can go ahead and take a look at our website, which is msfocus.org, and you'll be able to see when he's going to do those. And you can bring your questions if they weren't answered today. Just write them down and bring them next time, and I'm sure he'd be happy to answer them for you. So that does bring us to the end of this event. If you've missed any part of it, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Please reply to your registration email for more information by participating in a very short survey sent to you right after the webinar's over. You'd really be helping us learn the type of information and most meaningful and helpful things for you that you want to listen to. That's where we get our information from. That's where we choose the topics. At least we try. As attendees, that's very important. So please take part in that. Join us next time on Friday, March 21st at 4 o'clock p.m. with Dr. Susan Peyrovi. She's going to be presenting nutrition and supplements for MS. Thank you, everyone, for joining us today, and especially to Dr. Thrower for educating us on this really important topic. Once again, we'd like to thank our wonderful sponsors, Genentech, Novartis, EMD Serono, and Sanofi. Have a wonderful rest of your day, everybody, and we hope to see you again soon.